First up, I'd like to welcome Dr. Yiu, who's the winner of the Clive Archer Thesis Fellowship Award. This is a fellowship awarded annually by the Skin Investigation Society for the dermatology trainee who's completed the best MD and PhD thesis. So we're very excited to hear your talk.
Thank you very much. I'd like to thank the BAD for awarding me the Thesis Fellowship for this year. It's really an honor and a privilege, and also for the opportunity really to speak to you all today. So I'm going to talk about my PhD project, which is looking at the association and prediction of serious infection in patients with psoriasis on biologic therapies. So really, my research has stemmed from the clinic, so we're just going to use a clinical scenario and just pretend we are the dermatologists seeing the next patient who's coming in. And this next patient has psoriasis and it's not really doing that well on methotrexate. He's flaring and he's coming into your clinic and asking you about biologic therapies because he's read up on biologics in the news and on the internet. And he just has a specific question. He wants to try one of these biologic therapies, but he's worried about getting a bad infection. So that was the first aim of my PhD, to answer this question: what is the risk of serious infection in patients with psoriasis and biologics compared to placebo, and mainly looking at the clinical trial data that drives many of our treatment decisions. So I did a systematic review and meta-analysis, and this is one of the main results from this study. So this is a forest plot looking at one of the primary endpoints, the weeks 12 to 16 of many of these psoriasis biologic trials. And this is comparing biologics against placebo. And you can see here we're able to include many studies for each biologic, and each line and each dot is each study. Each black diamond is the combined estimates for each biologic, and then also combining all of that data together. And you can see that the black diamonds all cross that green line, the line of no difference, showing no significant difference. So it's good news. We can go back to our patient and reassure him and say, when we combine all of this trial data in psoriasis biologics, we haven't found an increased risk of serious infection in the biologics we looked at. And you can see that he's a little bit more reassured, but he has more questions for you. And he says that these biologics sound very safe, but what's happening after that week 12 to 16? And do you think there are any biologics that are safer than any other one? So that moves me on to the second aim of my PhD, to look at these commonly prescribed biologics at the time, etanercept, adalimumab, ustekinumab, and also infliximab, and see whether or not they're associated with a higher risk of serious infection now outside of the trial setting, in the real world, and also comparing biologics against each other, but also comparing against a group of patients on non-biologic systemic therapies. So to do this, we're very fortunate in the UK. We have the British Association of Dermatologists, Biologics and Immunomodulators Register, or BADBIR. We're all very familiar with BADBIR, but really it's a gold standard registry for psoriasis biologics research worldwide. And this is because of the strong external validity, the strong generalizability, because of so many centers being participators in this project, and us being able to recruit many patients. These figures are slightly out of date now. And also because of the study design, we're comparing two groups that are similar. So we've made a non-biologic group similar by saying you need to have a certain disease severity to enter this comparator cohort. And that really strengthens our comparison and makes sure that our comparator groups are similar enough. And I'm sure you all know the study design of BADBIR, the clinical follow-up, 6 monthly for the first 3 years and annually thereafter. And also we have strengths in linking that data with, for example, the hospital episode statistics, so we're sure we're capturing all of that outcome information. Another really important point to note is establishing the risk of serious infection. This is one of the pre-specified aims of BADBIR, to look at the safety of biologics. This means we can define the outcome before the start of the study, so everyone is working to the same outcome, which is listed on slide there. So that reduces what we call misclassification. So in this study, we were able to use biologic-naive patients from a snapshot in October 2016. And this is some of our main results. So this is a table summarizing the Crude incidence rates. So you can see we were able to include quite a lot of patients, just over 9,000, different number of patients in each arm, different number of follow-up time, again, different number of infections. But when we calculate that Crude incidence rate, you can see that these numbers look very similar. So there's no significant difference. But we have to bear in mind that we're looking at observational data and not trial data. So this means that these groups may be quite different. And this is because of something called confounding by indication. Essentially, it's doctors doing a very good job and choosing the right drug for the right patient. But this means that the baseline characteristics of the whole group between these drugs may be different. So just looking at these numbers may be misleading. And really, I'd like to summarize the issue by this quite busy table. So this is like a table 1 of a psoriasis clinical trial. So this summarizes the baseline covariates of the different comparator groups. And if I just highlight a couple of rows, you can see that maybe there are some differences. So if you look across this row, for example, for waist and BMI, you can see that that seems to be higher in the ustekinumab group. And that's not surprising, really, given that ustekinumab has a cost-neutral increased dose regimen for those above 100 kilograms. But you can see that for other comorbidities, for example, hypertension, diabetes, inflammatory arthritis, you can see some differences between the groups. And you can postulate that some of these differences may also impact on the risk of serious infection. So what we needed to do here was to adjust for all of these factors. What we did was a technique called propensity score weighting, essentially summarizing all of these covariates into one number, and then weighting all of the population so that the distribution of these characteristics are similar between the groups then before we do our comparison. So just to illustrate how that works, this is the same table after adjustment. And if I just highlight the same rows, you can see now these numbers look very similar, like a clinical trial. And so this reassures us that the balance of the propensity score has worked. So what happens after adjusting? This is the main results figure. Again, another forest plot. This shows the adjusted Cox proportional hazards models comparing these biologics against non-biologic. And you can see all of the risk estimates and the confidence intervals for unadjusted and adjusted estimates for all of the biologics cross the line of no difference, again, showing no significant difference. Now, if we pick out Infliximab, this is a bit of a special case. And as you all know, to get on Infliximab, you have to have a higher disease severity criteria. And that means that the confounding by indication is even more. So what we had to do is take this group out and just treat it differently. So we have less patients. We have 442. But as you can see for the first estimate, that's unadjusted, very high estimate. Adjusted, bit of confounding, but still with confidence intervals not crossing the line of no significant difference. So actually, we did find an increased risk of serious infection associated with Infliximab compared to the non-biologic systemic group. But anyhow, we can just combine that information and discuss this with our patient and say, look, when we look at etanercept, adalimumab, and ustekinumab, and compare this to a big group of patients on systemic therapy like the one that you're on, methotrexate, we haven't found an increased risk in the real world in UK clinics. And you can see that the patient's really quite reassured now, but has that lingering last question. And this is the question. Do you think some people are more likely to get bad infection than other people? So specifically, the question is, do you think it's safe for me, in particular, to have the treatments? So that moves me on to the third aim of my PhD, really to develop a personalized, a multivariable risk prediction model for serious infection. We chose infection within 1 year of starting treatment so that we can try and give some form of personalized absolute risk estimation for the patient. So this is what we came up with. What we did was to choose some predictors that we thought were important for infection. We then tested other ones in a backward eliminations logistic regression model, and this is what we came up with. So we chose, you can see that the treatment choices in there, some comorbidities, some lifestyle factors. And this was on a later data snapshot, so we had a few more patients, and absolute risk of 175 patients having infection within 1 year, or 1.7%. But before we use this, we need to know, is this model any good? Does it predict those patients who are going to have infections? So there are two things we can look at. One is discrimination. Can this model separate those who did have an infection from those who did not? And what we can do is look at something called C-statistic. This is exactly the same as the area under the curve. And you want this number to be as close to 1 as possible, but really above 0.7. So you can see we're not quite there, but we do have some clinical prediction from those predictors. Calibration, does the model predict accurately? Again, we want this number, the calibration slope, to be as close to 1 as possible. So it's not quite there, but it's pretty good. But the real utility comes, the test of utility comes on an external population. And what we did here was to ask our sister registry, the SOBEST registry in Germany, and get some data there and try and test this model on that particular data. And now you can see those numbers drop. So C-statistic really drops to 0.52, so that's equivalent to flipping a coin, really, not really doing the job. And again, calibration slope is not great. But what I like to do here is just to illustrate the potential of such a model if we were able to validate it on a population. So let's go back to our patient here. So we've got some clinical detail. You can see that maybe he does have a point. So we look at the baseline comorbidities. He's got a couple of comorbidities there. He drinks quite a bit. He's got a high BMI. And you want to start adalimumab. And when we put these details into the model, we come up with an absolute risk of 2.3%, which is higher than the general population in bad beer. So maybe he does have a point, but it is important to note that we don't have the sample size and the accuracy at present, so this is a 95% confidence interval, so we're not really precise with our estimates at this time. But maybe we could just highlight these factors and say, look, if we change your lifestyle, modify these lifestyle factors, actually drop the alcohol intake, modify the BMI, we can modify the infection risk. So this is maybe a good opportunity, really, to talk about these factors prior to starting a biologic for psoriasis patients. But that's not all of it. It does influence treatment choice. So if we change a couple of things and change the treatment choice to Infliximab, you can see that that infection risk does go up to 5%. So in the future, that might help us really direct treatment choice as well. So we're able to do this kind of study because we're collecting all of that real-world data, all of those covariates, all of the data that the nurses work so hard in putting in for each and every patient. That all counts because that detailed data capture means that we can use that for prediction or for adjustment. We have a lot of centers involved. This is the number in the actual data set I use. So it's representative of clinical practice. We're fully industry independent as well as in our data analysis. But we always have to bear in mind that this is observational data. There's always a possibility of residual confounding. That is confounding that's from these covariates we're not even measuring. And the model doesn't really perform that well. So in summary, I've shown you that there's no elevated serious infection risk if we just look at clinical trials in psoriasis biologics with serious infection. We haven't found any difference in the serious infection risk between etanercept, adalimumab, and ustekinumab, and these non-biologic systemics, but bear in mind that there was increased risk with infliximab. And we think that developing these prediction models may be of benefit in the future to help us discuss these modifiable lifestyle risk factors and maybe even direct treatment choice. So I'd like to end by acknowledging my funders, the NIHR, my University of Manchester, my supervisors, Professors Richard Warren, Chris Griffiths, Darren Ashcroft, but importantly, everyone involved, co-authors, participants of Bad Beer, the back office team, everyone supporting this massive project, and every one of you, and all the PIs and everyone recruiting patients. That all counts to make Bad Beer such a wonderful resource. Thank you very much for your attention.
Thank you. Fantastic presentation. Does anyone have any questions? There are 4 microphones scattered in the theatre. So I think we've got one question at microphone 4.
Hi, Phil Hampton, Newcastle. Zenas, I was just wondering, do you think there are any variables that you've not got in your model that might be important predictors for infection? Things like whether or not people have been vaccinated against flu, co-administered medications like prednisolone. Is that a potential weakness of this?
Yeah, that's a really good question. And I think the role of prednisolone, for example, compared to the rheumatoid arthritis population is probably a lot less. And just from a scan of people who are co-treated with prednisolone, there's not that many patients in Bad Beer and often therefore short courses. So I probably don't think that's a factor. I think probably some of these factors are going to be the biologic itself, the biologic drug levels. There's already early data from the rheumatoid arthritis registries that actually saying the biologic drug level after it's stabilized is associated with getting infection. So I think that side of it is probably those predictors to add in such a model.
And how about the vaccination issue?
Yeah, I don't know too much about that. I don't think that is going to be a problem because we are intervening there. We're telling people to be vaccinated before starting biologics. So my inclination is to think that that's not an issue, but that's not something I've looked at in particular.
Okay, thanks.
Yeah, Mike Hardin-Jones?
Yeah, thanks. Great talk. Are you happy that the Infliximab data is really comparable to the other data, bearing in mind the different sorts of patients they tend to be?
Yeah. Again, that's a really good point, and I am worried about this cohort. This is a smaller cohort, that's 440 odd patients, and as you rightly say, there's going to be a lot more confounding in this group. For example, we're treating them completely differently. We're bringing them into hospital. There's probably surveillance bias there as well. We're seeing them in hospital and picking up maybe even more minor infections and treating them in hospital. But I think it's important to take the evidence in the entirety. So just looking at other evidence, so for example, in the SOLAR registry, although that is more industry-sponsored, they also found an increased risk with Infliximab. So there's a little bit of signal that this is replicated in the different cohorts. But I would always look at this, although I'm presenting this data, I would always look at these data with a bit of a skeptical hat and just bear in mind that we're not able to take into account everything that could be confounding. Like, for example, maybe there are some patients that have escaped our vaccination schedules that we just don't know.
Thank you very much. I think we'd just like to say thank you for your presentation, Dr. Yiu, and we'll present you with the highly sought-after, cannot be bought anywhere BAD mug. So thank you very much.
Thank you.